everyone, and welcome to Wednesday Wellness, a free live educational series presented by Trinity Health Medical Group. Thank you very much for joining us this evening. Before we turn it over to our presenters, we would like to provide a few reminders. This presentation is being recorded, and you will receive a link to that recording over the next few days. If you have questions throughout the presentation, please use the Q&A chat bubbles, usually found near the bottom of your screen. During our question and answer portion, questions will be read aloud and then answered by our presenters. Without further ado, we would like to introduce Dr. David Hakopian, interventional physiatrist at Trinity Health Medical Group, physical medicine and spine located in Grand Rapids. Dr. Hakopian will be joined by Dr. Joshua Nicholson later in the presentation. Dr. Hakopian, thank you so much for being here.
Hi, thank you for having me. So just to double check, you can hear me clearly. It's working out.
Sounds great.
Perfect. Okay, so a little background about myself. I came over to Trinity about coming close to 6 years ago. My training is in physical medicine and rehabilitation through Michigan State University. I spent an additional year subspecializing in interventional spine with them and sports medicine fellowship before joining Trinity Health out here. And then primarily our group over at Physical Medicine and Spine deals with spine care from the initial phases towards, post-surgical and kind of the whole variety of what we'll talk about today. And then we also split some time doing electrodiagnostic, but that's the bulk of our practice here. We keep all of our time in the Grand Rapids clinic. And Dr. Nicholson actually is with me already today, so I'll let him introduce himself.
Hi, guys. Josh Nicholson, nice to meet you. So yeah, actually, Dave and I had a really similar process of training. We both went to Michigan State University for our residency, and fellowship was a little different. I did it through MSU, but I did an offsite location focused on interventional spine, and then I did the EMG fellowship training as well. So this is our bread and butter, talking about back and spine issues and trying to really spread the word about how important it is to kind of preserve and protect our spines as we age. So Dr. Hakopian is going to do the first part of the talk, and then I'll finish up with some of my recommendations.
And so we really are going to bring this back to basics. So this is targeting patients. We're going to really talk about the anatomy, because I do think it's very important to understand really what are the mechanics we're dealing with, what are the structures. When we're talking about preventative strategies, all of that ties in and helps really with adherence to any of these programs when we really understand what's happening and why things are changing. So our talk, my slides not moving. There we go. So our talk will really focus initially, well, why is this important? The epidemiology, prevalence of the conditions. We'll go through the spinal anatomy, definitions, so the remainder of the talk makes sense. Review some common spinal conditions, and then transition over the lifestyle factors, how to maintain a healthy spine, when to see your doctor, why do some treatments fail, and finally, when to see somebody like us, when to see a specialist. So why is it important? I mean, back pain is exceedingly common. 60 to 70% of individuals, though that's probably even light in terms of the percentage. Most people will experience back pain of some variety throughout their lives at some point. It's the most common cause of decreased activity in people over 45 years old. It's a leading cause of disability worldwide. It can impact people of any age, young to old, and has a very high associated healthcare cost. I mean, in the USA alone in 2016, one of the pieces of data I found, $134 billion went to taking care of back pain. Just globally, too, it ranks in the top 10 conditions for healthcare spending worldwide. So it's a very important condition to address, both when it's occurring, but also preventing it to help prevent some of these associated costs. The slide doesn't include this, but I mean, just time off of work, those types of economic costs are also one of the big burdens of back pain in general. So what are the risk factors that may develop into back pain? Really, it's a whole host of things, but physical comorbidities, meaning previous injuries, trauma, any surgical changes that have occurred with time. Chronic health conditions definitely factor in. Vascular disease, diabetes, depression can. Smoking we'll get into a little bit more, but in general, affects circulation, can also impact bone density, slow healing. Surgeries are impacted by all of those factors, so not good to have smoking on board when there's any kind of surgical intervention planned. And it has been linked to accelerated disc degeneration, definitely predisposing to further problems with back pain. Obesity is very complex with how it really impacts the back. For the hips, knees, there's a lot more clear-cut data for how much more force or pressure occurs, but the back is more complex. With obesity, it could just be the increased forces that are occurring or the changes in terms of where the forces are. So the balance of the spine itself can change the biomechanics of how you move and then wear certain territories out faster. But then also more wholly, the chronic low-grade inflammatory state can occur. That changes how our body perceives pain and what seems to trigger pain. So it's another factor to consider. And then, of course, extremes of activity. Too much or too little, all of those things can impact how much back pain might develop or how predisposed you might be to it. So positions where you're seated all day, very sedentary lifestyles, even truck drivers, those kinds of things we see very commonly, all the way to construction workers having so much heavy duty lifting, them wearing their backs out too. So there's a happy medium here that keeps the back healthy. So basic spinal anatomy, we'll talk about the vertebra. Those are the bones, the bricks that pile on top of each other to make the entirety of the spine. 7 in the neck, 12 in the thoracic, 5 in the lumbar. There's some variation to that, but that's really the gist of it. The tailbone, the large tailbone, we can call the sacrum. That's 5 fused together. So that's this bony plate all the way at the bottom. The pelvis will come attach right here. So in this first image, that person's facing us. This one, they're facing to the side that way. And then we got a person facing away from us where you can see the back structures there. Between each of the bones, we have the discs, will act like cushions, allow for some range of motion, and also gap these bones from each other and allow for these spaces directly behind them. Behind the discs are the posterior structures. Those will be the joints. They're called facets. They have cartilage. They have fluid, just like any other joint in our body, or most joints. And each set of facets in the spine is angled a different way, which allows for the certain motions of each segment. We'll talk about how those are in the next slide. Right in front of the facet joints, but behind the discs, that's the territory where all the nerves travel through. So that's the whole purpose of the spine, or one of the major purposes of the spine is to protect those nerves too. And each nerve will exit out of one of these holes, and anything that is occluding a hole, so whether it's a disc herniation or joints that are arthritic and thicker, may impact things that we'll talk about. Lastly, stenosis, just as a basic definition that'll come up. Stenosis is narrowing. That's all it means. It's thrown around a lot in x-rays or MRIs, but stenosis is narrowing. It can be anywhere. It can be in this middle territory all the way straight down, not well imaged here, but it's in the center, or any of the holes off to the sides. So our body is built with a general amount of leeway. Let's say one of the holes in the center is supposed to be 10 millimeters. If the structure that's passing through it's only a few millimeters, 5 millimeters, slight stenosis or narrowing is not impinging on that, is not compressing it. So mild, medium territories of stenosis may not actually be clinically relevant, but they're signs of some degeneration. And then nerve roots, I skipped over that one, but nerve roots exit at each of these holes and they travel down to specific sections that we'll talk about. Here's an x-ray, basic image to see, person facing away in this image, or towards us actually. And we're looking at the joints off to the sides, the disc spaces in between. The shape of the bones themselves should be nice and rectangular to allow for, enough space for the foramen and everything. And then on the lateral view here, you can see those joint spaces quite nicely and well. Here along the back end is that facet joint that will articulate or glide against the one directly below it. So you could already see based on this image in the low back, most of these facet joints are really allowing for that extension, flexion kind of movement. Now, I wanted to include a little 3D image so you can actually see and visualize what we're talking about. You can see that middle hole right in there spinning around, whereas the exiting holes are coming off to the sides. And then lastly, a structure that we don't touch too much about, just for time's sake with this, but the sacroiliac joint, where the pelvis joins in to the spine itself. That's another potential pain generator for back pain, very, very low back pain. It's a mechanical focus without numbness, tingling, or weakness necessarily, but that can occur as well. When we move off to the right side of the screen here, you'll see the facets represented a little bit clearer. Directly in front of them is that foramen, the discs themselves, of course, between the vertebra, and then you'll have to imagine a little annulus, or the disc having a little soft, squishy center. That is what allows for hydration and space, and then that's surrounded by a more tough ring of tissue that's at risk of injury. That can tear sometimes over time. That annulus might kind of give, and that allows for some of these protrusions or extrusions we'll talk about. So, real brief, the typical motions in the neck, mid back and low back, they all have some flexion, extension. So flexion is going forward, extension moving backwards, lateral flexion side to side, and then rotation, of course, at each segment. Most of rotation, or highest territory of rotation, would be the cervical spine. That's your head moving around. That's what it's designed for, so you can see all around. It's prone to injury because of its kind of free-floating nature, and then the weight right on top, just that moment arc, just the physics of it if you think about it. So it's prone to injury if you have any sudden acceleration, deceleration forces. The thoracic spine, I like to say, kind of cheats. It has the rib cage. It's not imaged here, but that rib cage wraps around and keeps it rather rigid. So the purpose of that whole structure there is, of course, to protect all the internal organs. But it makes it much more unlikely for the discs then to be under a lot of stress, or for the joints in that territory to get significant arthritis. So it's one area where much more commonly we see more muscular issues, postural issues cause pain rather than the direct degenerative territories that the lumbar and cervical spine are subject to. And then the lumbar spine, and if you imagine now, it doesn't have that rib cage. It's just these 5 bones sitting on top of each other that have to move, but it's also carrying a lot of your weight. So it's very vulnerable to improper mechanics, heavy lifting, poor posture when you're bending, twisting, prolonged sitting can apply too much pressure to the discs, cause damage, or repetitive movements that aren't optimized can cause injury to the facet joints. So how do you improve that? We'll talk later in the talk, but we need to strengthen that girdle of muscles around it. So if you just think of a balloon, that's the analogy I use for my patients. What happens when you squeeze a balloon? It gets taller, right? So there's less of that compressive force occurring. And so that's one of the ways that strengthening all the musculature around your abdomen helps. Then there are the muscles directly attached to the spine at each segment, the multifidus, the erector spinae. They will actually stabilize each segment and allow for more forces to be absorbed by the spine without translating them directly to those discs and the facets. So in terms of the musculature, the rectus, transverse abdominis would be that 6-pack and the corset kind of around the torso. Internal, external obliques, those are also the muscles that are around that torso, help with rotational movements. And then another one here to kind of visualize how much weight gets distributed as we're looking at this. 70% of that weight and force will go through that anterior portion, the front portion of the vertebra and spine, translate through the disc, 30% through the back. That is carried through the spine by having this kind of alignment, right? So this lordosis, they call it, the kind of extension position there, and then a compensatory thoracic kyphosis right here, and then finally that lordosis or curve back again. That is a nice normal shape to the spine that allows for this kind of loading to occur, because you're not supposed to get all of your loading through the posterior elements. That's not designed for that, nor are you supposed to get too much in that anterior portion. Perfect. Okay. So another territory or another thing to consider when we're talking about the anatomy of it, well, those nerve roots, when they exit, they supply very specific territories called dermatomes. That is what helps doctors figure out where might your injury be if you're complaining of or having numbness, tingling, pain in a certain territory radiating from the back or neck into a limb. And so each of these nerve roots is so well mapped out that we have a nice little map here. So if your S1 nerve is pinched, that's pain from the buttock, back of the leg, all the way out to the side of that foot. If it's the L3, it's more of the thigh, kind of stopping at the lower leg. So very helpful to know this as we're going through the examination. So we'll go through some common spinal conditions here. Osteoarthritis, disc degeneration injury, lumbar radiculopathy, otherwise called sciatica. Sciatica, interestingly, I'll just point out, we call it that because the sciatic nerve travels along the back of the leg, goes all the way down to the foot, but rarely is the sciatic nerve itself, which is actually in the buttock, the source of the issue. What we're talking about for sciatica is typically coming from the low back nerve roots that eventually turn into the sciatic nerve. Then we'll talk about general spinal stenosis, though in that middle hole, the main highway system, and then compression fractures and adult scoliosis. So let's look at the ages. How do things change in the spine as we're aging? It's much more likely that somebody in their 20s or 40s with sudden onset back pain is suffering from a disc-related issue. Typically, we don't have as much arthritic changes quite yet for that to be the main driver here, so that kind of makes sense. They might be involved in more physical activity. Maybe that's what's increasing that prevalence a little bit too, but typically 20s to 40s disc-related issues are much more common. Traumatic injuries from accidents, sports, all those kinds of things can contribute. In the 40s to 60s, of course, disc injuries can still occur, but there's a little bit of a shift now to degenerative changes. So degeneration of a disc or narrowing of the discs or joint changes, more arthritis in the joints, starting to become a factor. With both of those things occurring, now stenosis or narrowing in those structures that carry the nerves becomes a little bit more prominent. Chronic conditions like spondylosis, which just means degeneration in the spine, facet joint syndrome, pain associated with the facets, all those things develop. And then 60s and above, the above two things still occur, but now we also start thinking about osteoporosis related issues. Compression fractures can become problematic here. Age-related degenerative changes progress further, and more episodes of spinal stenosis can occur. So that's how things will change with time for the most part. So let's cover some disc injuries. Typically, onset, severe localized back pain. The discs themselves can be painful. Their adjacent structures can be painful. There can be a lot of inflammatory reaction to a sudden disc herniation, especially if that jelly material kind of leaks out. If it compresses a nerve, then of course you get those radiating symptoms, but right now we're just going to cover localized pain with it. Triggers, heavy lifting, poor mechanics, prior injuries. Herniated disc can occur with seemingly they can occur seemingly spontaneously or after trauma. Lumbar spine is most common, then cervical, lastly thoracic. Makes sense with the anatomy we just talked about and the types of ways these move. A bulge would be just a broad kind of bulging out all the way around, or just a large percentage of that peripheral territory, 25%. Those are very, very common. Herniations would be classified into protrusions, extrusions. Really just depends on the size of it for lack of the details here, but protrusion extrusions target a specific territory more so. It's just like a tear in that lining of the disc, causing it to squeeze out. And extrusions are just a little bit more of that jelly material, typically covering a bigger territory once it's out of that disc. So here's a visual representation, a normal disc along its circumference. That's a nice symmetric disc bulge all the way around, very common to see. An asymmetric disc bulge off to the side. Then you get your herniations, right? So here's a protrusion and then extrusion where that jelly really leaks on out. And then sometimes that can just get walled off and sequestered, and then you get this little fragment of disc. Degeneration is different. Degeneration of a disc is just slow dehydration of the disc itself and thinning of the disc. It doesn't necessarily have to have a herniation or bulge with it. Modern medicine doesn't do a great job of really differentiating a normal aging disc versus degenerative disc. We kind of just have trends depending on how old a person is. With age, disc fluid content diminishes by a relatively small amount. By age 30, we've seen disc injuries are found commonly in anatomic models. Multiple factors lead to degeneration, right? Genetics, environment, repetitive microtrauma, spinal conditions or degenerative spinal conditions like facet arthritis, ligament thickening, they all coexist, and the interplay for how the disc degenerates in conjunction with that is not totally well understood. One very important comment, though, is people who are asymptomatic often have these things. So having disc degeneration does not equal having back pain or a degenerative disc disease necessarily, right? I'm not a fan of that terminology. In 20-year-olds, 37% can have disc degeneration. They have no back pain. In 80-year-olds, 96% are going to have some level of disc degeneration with no back pain. Disc bulges are a little bit less common. Finally, disc protrusions, even less so. And then those fissures are that lining of the disc itself, the annulus can tear. Those are less common even yet, but still occur in patients who are asymptomatic. Disc recovery, very, very common on its own, spontaneously in 85% of patients within those 8 to 12 weeks after it occurs. Extrusion, 76% of the time, will show complete or partial resolution by follow-up. And if symptoms persist past those initial few weeks, then of course physical therapy should be considered, talking to your doctor should be considered. Home care is avoiding bed rest or total bed rest. Gentle activity is best. Avoid weighted forward flex positions that aggravate the symptoms, typically Tylenol, oral anti-inflammatories. If you're able, contact a physician, of course, if it's impacting function. Radiculopathy is related. Now you're pinching a nerve, so you're getting pain down these territories of the dermatomes, or numbness or tingling. The distribution is going to follow that map, and you may have associated weakness if the muscles, those nerve supply, are affected too, or if the nerve is affected bad enough to cause muscle weakness. That's ever noticed, of course, that's more see the doctor, make sure we're figuring out why and what's going on. The management is very similar because the cause is the same thing. It's just where did the disc herniate now? It herniated where a nerve happened to be. So how this recovers is very similar to just a routine disc herniation. Postural correction helps, targeted exercises help, physical therapy, anti-inflammatories. The difference here becomes with radiculopathy, sometimes steroid injections are brought up. Steroid injections have good evidence for short-term pain relief. Long-term, it's still about the same as conservative treatments otherwise. But in the short term, if a month and a half, 2 months have gone by, medications, therapy is not helping it, activity is limited, steroid is injected in the territory around that nerve that might be irritated, and it can calm things down a little bit more. Surgical treatments are really only for unrelenting pain or evidence of severe nerve damage on exam, so after the doctor determines it. Osteoarthritis will occur in those joints directly behind that disc space, right? So facets will have breakdown of cartilage and joint surface, just like your knees, your hips. That can lead to pain and stiffness. Classically, I see this present as this dull, achy neck or back pain, worse with inactivity, worse in the mornings. People usually see us for this because they're sick of dealing with it over time. It's not the type of pain that's causing a person to go to the ER or is incapacitating. This is different. It can be worse first thing in the morning, and then with poor ergonomics causing pain once you change position. It can refer though, so it doesn't have a nerve involvement necessarily, but people will have pain traveling to different territories. So this has been mapped out in other studies. So in C6-7 in the neck, if that area gets arthritic and painful, they can have pain going all the way to the shoulder blade. Up high, it can go towards the back of the head. Similarly for the lumbar spine, there are territories that are mapped out. So that can be helpful in our exams to localize where things are from. This is also what physical therapists do. So there's often a very there's often a push towards imaging to see what is wrong. But really, when we're evaluating you, like good physical therapists do for the spine, the evaluation tells us what's wrong and where the symptoms are likely from. And then treatments initially are really based off of that. So we get similar info in those initial periods from our physical exam as we might from imaging. Facet joint pain, managed like any other kind of joint pain, anti-inflammatories if approved by your physician, if it's significant enough, physical therapy to stabilize the musculature around it and take off some of that weight from the joints themselves, modify what might be causing your pain or provoking activities, of course, and then if not improving, getting a consultation with a specialist after you've seen your doctor. So both of those things now, disc degeneration, bulges, now joint arthritis, they're adding up. Time is going on. Lumbar stenosis becomes a little bit more of a player. And that's the central canal stenosis. Here you'll see in this model that main highway system where all the nerves travel through, and the exiting canals where the individual nerves will go. I really use the analogy of a main highway and then exit ramps, right? These are all the territories where those dermatomes and myotomes are going to be targeting. When you look at this MRI, you'll see this middle hole. Now, white stuff is the fluid that all the nerves are traveling in. That's that central canal. Disc bulge narrows it. That's that mild to medium stenosis or narrowing. But you can see there's still plenty of fluid. Those nerves aren't being pinched. So in this kind of case, I wouldn't really expect symptoms from any of these nerves. It's just this disc. Whereas now you add in maybe a slip where one bone's moving forward a little, you add in some joint arthritis directly behind it. Now you got a double whammy. There's not as much fluid there in that middle territory. Now those nerves are getting kind of squeezed together. That is usually a slow process from both of those things occurring over time rather than a sudden change. And it'll present itself with symmetric back pain, buttock pain, aching, fatigue in the legs the longer you stand and walk, cramping sensations, and classically leaning forward helps. It opens that spot a little bit, called the shopping cart sign. Management is still typically non-surgical. Really, for any issue that's causing walking inability, difficulty with function like that, see your doctor so you can get an examination, make sure it's not blood flow related, make sure it is from the back. Then physical therapy has been shown to still be helpful for function at 1 year. Epidural steroids are a little less effective for this, so they have their place for short-lived benefit, but a little less effective. And then there is lack of moderate to high-grade evidence for non-operative treatment for short-term outcomes, and some results favor decompression or surgery for long-term outcomes when it comes to this central stenosis. If it's bad enough, it's consistently just mechanically squeezing those nerves, they're losing their blood flow, the symptoms develop, so they decompress that spot and open it up, and the results are rather good for that kind of localized thing. Okay. Compression fractures. So that's a collapse of a weakened vertebra. It's not a direct crack, but it's a squish basically of the bone that's become weakened. Happens from osteoporosis, can happen from trauma, or cancer that weakens the bone. It is quite painful, severe, sudden. If you've had multiple or they're just slowly occurring over time, there can be height loss. Changes in posture can occur depending on where the compression fractures are happening. You can get more forward flexion of that thoracic spine with time if that's where they're occurring. Importance here, which Dr. Nicholson will talk about more too, is maintaining your bone health. So vitamin D supplementation, calcium supplementation, these are things that your doctors will discuss with you. Bone scans become routine after a certain age. Weight-bearing exercise is a great way to fight this off because bone builds density and has a trigger to become tough with weighted exercise. Astronauts go to space, they come back with less bone density because their bones are just not undergoing that same amount of force. Same thing happens if we're sedentary all the time. We're not putting any force to our bones. They lose the need to be stiff and put up with force. And then avoid smoking and excess alcohol. Treatments for compression fractures are really physician guided. The pain is significant. See them, get an exam. You got to limit the activities that are aggravating the pain in the moment. Bracing can be helpful to help stabilize the segment and relieve some pressure. Therapy can in fact be helpful even in the acute phase from the fracture. And then interventions like vertebroplasty or kyphoplasty are basically injections that are done into the bone itself of a cement-like substance that solidifies and stabilizes it. That happens typically with failure of that conservative treatment path initially. And then scoliosis, I'll just quick because I'm running out of time to transition with Dr. Nicholson, but scoliosis is a different structural change. For adult scoliosis, the majority of the time I see this is from asymmetric degenerative changes, slowly over time changing the alignment of the spine. This is very different than juvenile scoliosis, which can be more rapidly progressive when the bones are forming. In this case, the adult spine is solid. It is formed, and so changes, if they occur, usually occur very, very slowly over years. It's very rare for me to see an adult with scoliosis that's mild or even medium progress to needing surgery for it. So that's very rare for adults. The bracing for scoliosis is also rather ineffective for adults because we're not going to reverse it by bracing. The mainstay treatment for it is type of physical therapy, Schroth physical therapy, that really focuses on the deep stabilizing musculature so that they're stronger and they hold the structure of the spine more stably. And then avoiding postures that basically predispose to agitating your joints more. Treatment otherwise for pain associated with the scoliosis is really just targeting where is that pain from. It's not from the scoliosis as a whole, but it's a local territory of the scoliosis that might cause a focus of joint inflammation or a focus of nerve impingement. So that's what we focus on when it's pain related to it. The rest is management of the overall spine health, really. Yeah, the other stuff I just covered. So I'll switch over with Dr. Nicholson.
Great, thanks. All right, so after that really nice summary of spinal conditions and its prevalence, what I want to talk about is trying to kind of full circle come back to, well, what do you do to prevent these things? What do you do to help stabilize your spine? So preventative strategies. First off, the kind of beginning of this is just kind of my top 10 of things that I would recommend and hope that people know about to protect their spine and to work on. I really like this quote, Joseph Pilates. Pilates is a style of exercise that specifically does a lot of focus around the spine and the core. And I love this quote. It says, "You are only as old as your spine." Don't know if that's exactly true, but I think it's a good reminder in our field that the spine really matters, and keeping mobility and strength around it is a super important thing for longevity. All right, so top 10 things. Number one, obviously rehashing the don't smoke. We're definitely on a soapbox here about it, but it's a big deal. It's been shown to increase inflammation systemically. That inflammation is bad for your heart. It's bad for your lungs. We know that leads to cancer risk. But in terms of the spine, it can actually increase the development or likelihood of osteoarthritis, which it also happens to weaken the bones and prevent the ability or delay your healing capacity, which this is big stuff, especially with your back, because your back's always being used, right? So little strains or tweaks, you want those to heal quickly, and smoking really impairs that ability. Number two, I would say posture is one of those things that, you know, if your mom's not around to correct you and tell you to sit up straight, it's one of those things that it's hard to know if you're doing it right. So having that evaluation and making sure your posture is right and thinking about it takes practice. So I like this picture, shows kind of the far right image here of appropriate posture. And you can see on the far right, there's the ear that's over the shoulders over the hips, and the hips over the ankle. Now, you can see in different examples, I'm sure you recognize the majority of these postures. You can see people, you know, go to Walmart and see what people look like. And to be honest, this is not uncommon that you'll see a lot of these postures. It's because of chronic changes that have been happening. And if we catch those early enough and we're conscious of them and we strengthen the musculature that holds our spine in good position, you can actually bring about changes or at least stability to prevent it from wearing more excessively. One thing to think about with this is, well, how do you do that when you are unconscious about some of these things? You're at work, or maybe you're at home and you're just watching something on TV. Those kind of patterns, we spend a long time or a lot of our time during our day or night doing those things. So trying to set up your environment to have good ergonomics is important. This is one of those things that you kind of have to think about and spend some time. But if you look up good ergonomic furniture, they have a lot of that for workspace, and you can also apply those rules to at home, especially if you're, working on a computer at home. And since the pandemic, there's been more of that than ever. So setting up a home office that has maybe a standing desk or maybe has an adjustable desk that gets you to be at an appropriate height for your body. Obviously, the last one's a big one, lifting properly. This is one of those things where we see somebody who's like a construction worker or maybe a drywaller, somebody who's doing things where they're lifting repetitively and they're in awkward positions. They really need to take care to maintain their spine. And of course, there's the kind of demands of your job that say you gotta, work fast. But the reality is, if you get injured, it is tons of time away from work. It's tons of money lost. It's important to really take care when you lift. So pay attention to those. The organization that does this is called OSHA. I'm sure many of you have heard that term. It's Occupational Safety and Health Administration. They have specific lifting guidelines. And I would say if you're unsure of those, that's a great place to look. So number 3, take breaks. Actually, it's funny. Here we are talking about spinal health, and we've been sitting the whole time. I do think it's actually pretty important that on a time frame of about once an hour, you should be doing some motion where you're getting up and moving around for at least 5 minutes. That's actually been looked at, and people who do that are less likely to have repetitive kind of injury of the spine. That's helpful. And I like this little graphic here. It's some simple stuff you can do, even if you really can't necessarily leave your desk, but here are some moves that are easy to do. One of the best things that's been shown to do is actually get up and walk. So maybe walk down to the water cooler. Maybe if you're at home, go outside, take a little walk around the block and come back. Trying to break it up this way has also been useful for stimulating your brain. People who have really looked at attention spans, once you've been sitting for longer than 30 minutes and trying to focus on something, it starts to drop off. So you guys all paid attention to Dr. Hakopian, but I guess I'm, chopped liver here. Nevertheless, it's one of those things that, it stimulates your brain, it gets you more awake, and it's also really important and good for your back. So regular standing, moving, that's an important part. Stretching, it prevents muscle fatigue and development of stiffness. So number 4, maintain a healthy weight as best you can. We know that weight by itself is not an indicator of for sure that you'll develop back pain issues, but if you have excessive weight, we know that it does stress and strain the spinal structures. That's been looked at with some studies where they actually looked at the forces through some of the disc structures, and that was also based upon the weight dynamics that people were carrying. So this is one of those that if you can, do your best to control your weight. This is a great place to, talk to your primary care about that, work on some of those weight strategies. And also, I've got some other tips around diet and exercise that I think will kind of lend itself to maintaining a healthy weight. Number 5, staying hydrated. I think that's another thing. We get this general recommendation of, have 8 glasses of water per day. The reality is that that's a general rule of thumb. It's not a set in stone rule. You can figure out what's appropriate for you, but what's been shown is that if you're dehydrated, actually, you just don't have as much muscular capacity. They don't perform as well if you're dehydrated. And then also that applies to some of the science around discs. If you're not hydrated well, it's theoretically reasonable to consider that the discs that supply the cushion in between your building blocks of your spine, the bricks of your spine, aren't going to be as well hydrated or as full. So, this is stuff that you can do throughout your day to maintain good health. Also, I know this is a little maybe gross, but probably one of the best indicators of how to determine if you're hydrated enough is by looking at the color of your urine. You want it to be more on that kind of light yellow or clear side rather than the hyper-concentrated yellow or orange color. That stuff is a simple way to see where you are in your day, and also just a reminder to stay hydrated. All All right, number 6, really important, balanced diet. I think one thing that I've come to realize personally is that we talk about healthy eating, but one thing that's been kind of popularized in some degree amongst the sports medicine physicians is protein, but it hasn't necessarily converted to regular consumption for average Americans. So I would say, first of all, there's kind of a prioritizing of which foods you're eating. And one of the guidelines that we talk about is thinking about food as kind of medicine, this anti-inflammatory effect of food. One of the diets that's been championed this way, especially for cardiovascular health and overall systemic inflammation, is the Mediterranean diet. So I've included a link there. Healthline has a nice little write-up about their Mediterranean diet. It gives you kind of a 101 plan of ideas and strategies to look at. Additionally, down at the bottom, I included the Harvard Health. That has a great one about nutrition as well. So checking out those websites. Now back to the protein. So protein, if you think about the average American weighs about 180 pounds, the recommended daily or dietary allowance or dietary average is a number that's been created to, on average, meet your minimum successful intake of that nutrient. And so, and it's looked at a population of 97% of the population will meet their dietary recommendation if they're consuming that. So FDA recommends that you're eating about 0.36 grams per pound. So if you're 180 pounds, that equals about 65 grams of protein a day. That's actually a lot. And I know a lot of people who don't do that. And that's for basically the bare minimum. American College of Sports Medicine recommends actually quite a bit more than that. They recommend 0.8 grams per pound. So now 144 grams per day if you're the normal weighing 180 pound American. That's a lot of protein. I work hard to try to do that in my own life, but it's actually challenging. So really trying to prioritize high quality lean proteins is important. And I would say it's been shown to really help with muscle density, also bone density, and basically physical capacity. So it's one of those things that I, champion or try to talk about. So number 6 here. All right, number 7. So definitely important to include physical activity. And I would say physical activity that's non-work related. I have a lot of patients who are, housekeepers or construction workers. And these are people who are very physically active, but the nature of the job that they're doing is repetitive and it's also tough on their bodies. So what I'm speaking about here is specifically physical activity that's not pain triggering, but that you can focus on and actually hopefully helps to train some of the musculature that gets worn out or that isn't being used as much during your day. So American Heart Association, that's the AHA, and the Department of Health and Human Services recommend 150 minutes of moderate physical activity per week. Or if you're doing more heavier, vigorous intensity exercise, they say 75 minutes per week. So I'll get into some of that, trying to break that down. So if you're trying to think about developing a plan, one of the real goals, in my opinion, is we're all, kind of stressed for time and life's busy and maybe we got kids and maybe you're run grandkids around or, whatever. Family life is what it is and work life and balancing all of that. So how do you combine some of these activities to really find the ones that are high yield for you and maybe do multiple things like work on your strengthening, work on stretching, work on your cardiovascular capacity, maybe even provide some level of relaxation. So this is, again, another Harvard article, same that Harvard Health Publishing put out. There are 5 best exercises that you can ever do. It's really a sensational headline, but I would say they included some really good ones. So walking, swimming, strength training, Tai Chi, and Kegel exercises. So I'm going to go through some of these. So walking, pretty obvious. I'll talk about where that falls in some other slides. Swimming, pretty obvious. It's actually a really excellent exercise and it's less stressful on the bottom or on the body. Strength training is a really important one as well. And it goes in line with what Dr. Hakopian was saying about the components of bone density, maintaining kind of capacity inside of your spine to be strong and actually kind of work to protect those structures as we age. So now the next two, I'm going to dig in a little bit more into detail. So Tai Chi, it's a more relaxing technique. It's more of a meditation movement. It's actually a Chinese martial art, but it's one of those that has really been incorporated as clever ways to even do Tai Chi or motion movement while sitting or standing. So there's lots of adaptation. So I include that. If you're interested, that's a good one to look up. And there's actually services around the community that offer Tai Chi. Now, Kegel exercises. This one is kind of a thing I like to talk about just with my patients because it's such a simple thing to do to bring core stability and to work on the pelvic floor musculature. So a Kegel is basically an exercise where you contract your pelvic floor. The idea is imagine trying to like kind of stop a stream of urine, that kind of tightening of the lower pelvic floor. The purpose of this is actually to tighten those muscles, and you can do the exercises relatively simply. You can be sitting in a car, you can be at a movie, you can be at work at your desk. The idea is to basically contract your lower pelvic floor, hold it for 3 seconds, and then completely relax it. And to do this for about 10 times. If you can do that in a day, that's been shown that it builds this tolerance. And actually, these Kegel exercises can help support the core musculature that then can help support your back and your pelvis. All right, so sorry, this is a little fuzzy. It's a picture that comes from the United Kingdom's chief medical officers. They put out some images of what to do. If you focus on the different categories on the far left, the sedentary one, this is pretty obvious, self-explanatory. One thing I would say is, we talk about relaxation, the importance of that, but that middle one's supposed to show meditation. And if you think about it, meditation can be done in lots of different ways, or relaxation can be done in lots of different ways. If you already do a lot of sitting, I'm not sure, doing more time sitting is necessarily the best move. Maybe finding some other relaxing technique might be better. Some of the other things you'll see under the category of light, there is light physical activity. There's cleaning, carrying out rubbish, and then they do yoga here. They show yoga. Yoga has been shown to be actually quite helpful for the back, especially because it works on stretching and core stabilizing. But the traditional sense of yoga is actually, or the traditional practice of yoga is more on the light level of intensity. So if we go back to that recommendation from the American Heart Association, we're supposed to get 150 minutes per week of moderate level physical activity. So here's the next one in the middle, that kind of dark green one. It says walking, cycling, or shopping. I don't know who moderately exercises while shopping. So I feel like that's a weird one. I mean, unless it's me chasing after my wife, hoping she doesn't spend all my money. I don't know. I would say the other two examples of cycling and walking make more sense. So walking is a really good one. And so it's also one of those ones that Harvard recommended. And it meets the criteria of that 150 minutes. So if you get more serious, we start to talk about the vigorous activities, and this is where swimming falls into it. So vigorous would now be in that realm of where you're now needing to meet 75 minutes of vigorous activity a day, in a week, to meet that criteria of kind of healthy cardiovascular capacity. So swimming, if you're doing that, you don't have to do as much of it because it's higher yield. But some of the other ways to enjoy this is playing, maybe kicking a soccer ball around, maybe dancing. These are things where if you're more physically active, you actually have less of a total time requirement involved. And also, playing or dancing, that can be a lot of fun. So incorporating some of that relaxation into it. And then we get, into the very vigorous stuff. So very vigorous is heavy weightlifting, push-ups, or if we're doing sprints or, upstairs that are running upstairs, those kind of things. That's really max capacity. That's where, you actually start to run the risk of maybe even hurting yourself if you're going so vigorous. So really do that one under some guidance. And that's the key, is that if you're doing, gym activities or strength training, you really want to know how to do them in a way that doesn't harm you. So work on maybe working in a group class or working with a trainer, somebody who can show you how to do that safely for your body. All right. And then number 8, manage stress. This is a huge one. Managing stress is just like what we talked about. If you can find ways to incorporate that into your day, maybe talking with friends. I love to have lunch with Dr. Hakopian. We get to review our work stuff, but it's also a good way to talk to one of my friends and kind of, vent about the day. Spending time in nature has actually been shown to be one of the best things to do. And then, things like listening to music. How about listening to music instead of the news? News just stresses everybody out. Try to listen to some music instead. Or maybe you love to read a book. Do that instead. So working on these techniques, it's been shown that if you can reduce stress, this really can help with not only other medical conditions, hypertension, obesity, but also it can help to reduce muscle tension and back pain. And also maybe leaves you in a position where you're making healthier dietary choices. All right, number 9, sleeping well. Sleeping well. This is a super important one. So, work on trying to create a routine where you really are doing the things that create a space and an environment where you can actually fall asleep. One of the big ones is don't stare at your iPhone or your phone before bed. Try to instead maybe read a book, maybe create, or, one of the most important is just create the space that actually works for you. Some people really like it to be quiet. Maybe you're, around your apartment or house, it's noisy. So maybe actually, have a sound machine, that kind of a white noise machine that can help, but keep the room dark. Try to create an environment and a consistent routine. This has been shown to help improve stress, helps improve overall health, and actually helps to improve spinal health, especially if you're using good spinal alignment. So good mattress, good pillow. There's no particular brand that's really good. It's actually more important to go to the store, check which pillow actually works for how you sleep. So, one of those mattress stores where you actually lay down on the mattress and feel how it feels. It's probably the best way to buy a mattress or a pillow. All right, number 10, most important, just listen to your body. If you're really having persistent symptoms and these things and these tips aren't working for you, make sure to get evaluated. It's super important, because if we can figure out what's going on, there are ways to help you. All right, so some of my additional recommendations. I'm running out of time here, so I don't want to go too in depth, but walking. It's so easy. These are my personal ones that I try to incorporate in my life. So walking, if you can do 20 minutes a day at a roughly moderate pace, 20 minutes isn't that long. It naturally improves blood flow. It helps alleviate stiffness. It also increases that kind of gliding of the neural structures, those nerves as they pass through the foramen, or the holes where they pop out on the side. That allows those nerves to kind of move and glide and keeps them from being stuck and irritated. So if you did 20 minutes a day, that's 140 minutes of moderate activity per week. So already now you only have 10 minutes left to do to meet the American Heart Association's recommendations. So next one I really like to do, strength training. As long as you're working with somebody who knows how to help you and do it in a healthy way, it promotes bone density, which is great for that long-term health, helps to create stronger core musculature, and then also it works to basically strengthen the surrounding structures of the spine throughout. Again, though, if you're not doing it right, it's an easy way to injure yourself. So really recommend that you work with someone on that one. All right. Number 3, this is a personal one of mine. It's partially because my wife's a Pilates instructor, but it's a fantastic exercise to work on core stability, spinal strength. So I include this because there's also, if you've had pre-existing injuries, what's great about Pilates is there's lots of modifications to those exercises and ways to do them so that it can basically work with your injury to still strengthen your spine. So it's almost like a long-term way of maintaining good spinal health. Highly recommend it. Next one, yoga, just because it's so popular, wanted to bring it in. Some of the best things about it is that it has a reducing of stress capacity, breathing techniques, meditation. There's a philosophy about it. It's been shown to alleviate pressure on spinal structures temporarily. It's good for flexibility. Sometimes, in fact, it's one of those where I've seen people actually hurt themselves doing yoga because they're wanting to be teacher's pet and stretch the furthest in class. So just remember, any of these exercises, really listen to your body, pay attention, make sure you're not hurting yourself with these exercises. All right, so sometimes treatments fail. Why do they fail? Well, sometimes individuals have different responses to those treatments. And so sometimes that's because individuals don't do the treatment correctly. Sometimes it's the treatment's the wrong one for you. Sometimes it's because of some underlying structural or anatomical difference that needs to be worked up. Sometimes it's because you've had a pre-existing injury and that really needs to be addressed. And then honestly, that inadequate diagnosis, if you're having persistent symptoms, that's when to see your doctor, because having a good diagnosis is really important to know what you're treating, and that way know what you're doing to protect your spine and not make it worse. All right, so basically kind of leads into this slide, when to see your doctor. I would say if you're doing things to try to treat some of your symptoms, you've tried those conservative care, ice, heat, stretching, gentle strengthening, you're trying to avoid the activity that hurts you, tried some over-the-counter medication, and you're still having pain, it's time to see your doctor. I said, if you've done all that and it's been over a month, I'd recommend making an appointment with your physician. Now, if you're recently injured and you have the onset of back pain or spine pain rapidly, that requires you to be seen right away. So this is general guidelines of when your pain is affecting your daily activities and you've tried those conservative care things. If you're not getting better, talk to your doc about it. All right, so when is it necessary to see us? So spine specialists. I would say if you are already trying to go through that conservative treatment, you've had your initial assessment, things are not improving with those initial treatments like physical therapy, or you've tried some of the initial meds and they're not getting better, or more seriously, you've developed things like persistent numbness or new onset weakness, bowel or bladder incontinence, or walking difficulty. These are actually kind of emergency things. So you really need to be seen if you're pooping or peeing your pants, or if you're not able to walk and you used to be able to. If you have new weakness, this requires you to be evaluated. So super important that you know those, but obviously it's one of those that if you're not having a response that's successful to your primary care physician's treatments, come and see us. All right, so finally, specialize or the specialist, what can we offer? Basically, we have a whole focus of basically treating your back. This is what we do. I'm not good necessarily at treating conditions like diabetes or high blood pressure, but I'm good at treating the spine and spinal conditions. That's what I focus on. So, and we can also offer things like more advanced imaging or diagnostic treatments or diagnostic options to figure out what's going on. We can also offer more advanced treatments. Sometimes that's fancy versions of therapy, specialized medicines, or even the procedures that Dr. Akopian was talking about. And then finally, we can make sure you don't need surgery, or maybe you do need surgery. We can help coordinate that quickly. All right, well, thank you guys so much for your time and patience with us. Yeah, we're pretty close to the end, but I think there might be some questions. So we'll turn on the audio and chat here.
Yeah, so thank you very, very much. We are going to transition to questions. So again, if you have a question, please drop it into the Q&A bubbles down at the bottom, and then we will read your questions aloud and have our presenters answer them. And we did receive several questions prior, but I think that you guys answered them all really well. So we are going to jump into the ones that we received this evening. So what is your opinion on chiropractic care?
Oh, that's a great question, and very, very common that we get that. I mean, chiropractic care, I would say, has its role for certain conditions, but if you're going to the chiropractor repeatedly for weeks, months, and you're not being told how to change what you're doing at home, you're not getting exercises to change things, decrease the frequency at which you're going, that's problematic. The main thing I say is for the lumbar spine, mid-back issues, it's very unlikely to cause any harm as long as you get care if your symptoms are severe. I've seen plenty of patients get benefit from it and like it. It's just I want to make sure that they're also teaching you to be self-sufficient with the techniques and decrease the amount of times you're having to see them. The one thing I would add is for cervical spine, I think a lot of chiropractors have gone this way, but I'm not a huge fan of aggressive cervical mobilizations, especially for people, 50s, 60s, 70s and on, for spinal alignment issues for the neck. That kind of stuff I think even most chiropractors these days are using more gentle techniques because they can have some problems with that. But as a whole, it's reasonable to see them. But if pain is not improving, I'd say go and see your doctor. Yeah.
I agree. Yeah, it's a tool in the toolkit to use. So yeah, I would say I completely agree with Dr. Akopian. It's one of those where it can be a useful tool, but it's something that if it's not fixing the problem, it should not be the end all be all.
Thank you. When it comes to spine health, what is the best position to be in when you sleep? On your back, on your side, with a good pillow? What do you think?
This is a tough one because the reality is it has a lot to do with individual spinal anatomy. So it has to do with which one you can well tolerate. So I sometimes use the expression pain is a canary in the coal mine. If you're having pain in those certain positions, try to find one that is able, a position that you're able to change to that might alleviate that. And so it's actually probably a good idea to not also sleep in the same position every night in the same way. So having the ability or maybe multiple pillows that allow you to be a side sleeper temporarily, or then maybe sleeping on your back. I would say probably sleeping on your stomach. That's one that's probably not great for the long run. I mean, you can do it, and some people really find that to be the most relieving position, but that's a small minority of people.
Yeah, I'd agree. The sleeping on your stomach, if you have to pick a position to not do, I'd say that's the one. It'll accentuate the extension position of the low back, so kind of predisposes to developing joint pain in the low back, as well as puts you in a significantly rotated cervical position a lot of the time, so increases issues there. But side lying, laying on your back, as long as you've got good support, either of those are fine. It's very individual driven.
All right, thank you. We are at 8 o'clock, so I might try to sneak in one more question really quickly, if that's okay.
Yeah, you bet.
Is bike riding or walking better if you do it regularly?
Yeah, so I looked into this. So there's some science around both of those. From a cardiovascular standpoint, actually, both are fantastic. From a spinal standpoint specifically, actually walking's been shown to be a little better, and it's just because it's been studied and it's been shown that some of that nerve gliding or flossing techniques naturally happen when you walk. Now, I would say this one's important. Some people, and sometimes people with conditions like stenosis, actually find the seated position of cycling a little easier on their body. And so finding the exercise that works with your condition is a big part of spinal health. And so when it really comes to it, let's say you have a lot less discomfort and you find cycling to be rewarding, I would cycle. I love to cycle. It's actually my preferred way. I walk the dog. That's how I get my 20 minutes of walking. But if I had a choice, I'd be cycling.
Yeah, I agree.
Yeah.
Well, thank you. All right, well, it is 8 o'clock, so I would like to thank both of you, Dr. Hopian and Dr. Nicholson, for an excellent presentation and Q&A session. And we would also like to thank everyone who joined us this evening. And we look forward and hope that you join us in the future for future Wednesday wellness topics. Thank you again.
Thank you very much. Have a good night.